All right, everyone. So it is noon. We are going to go ahead and start. Hello and welcome to our education series on competency evaluations in behavioral health in New Mexico. My name is Angelica Goodale, and I'm a research scientist with New Mexico Sentencing Commission. In addition to myself, I will be followed by our guest speaker, Scott Patterson, the statewide behavioral health manager. If you have any questions throughout our session, please use the Q&A area and we'll try to answer them the best as we can. Today, we're going to be talking about competency evaluations in behavioral health in New Mexico. First, I will go over competency assessments for fiscal year 2019, followed by Scott Patterson, who will go over current New Mexico mental health and treatment courts, as well as other programs in place to assist those with mental health issues going through the criminal justice system. Lastly, we'll briefly go over some top-rated and reviewed mental health programs around the country from the National Institute of Justice. When the question of the defendant's competency is raised, the proceedings in the case shall be halted until competency is determined. Incompetent is distinct from insanity. There are three main points when considering competency: the defendant's ability to understand the significance of the proceedings, and if the defendant has factual understanding of the charges, and if the defendant is able to assist counsel and defense, while insanity is more concerned with the defendant's mental health state at the time the offense was committed. Lastly, because incompetent defendants cannot be convicted because it legally violates due process, defendants found incompetent cannot be brought to trial in the same manner as those found competent. In August of 2020, New Mexico Sentencing Commission produced a report regarding competency assessments for fiscal year 2019. The purpose of the study was designed to examine competency processes in New Mexico and identify if there are any significant differences regarding key variables during the timeframe. Additionally, we wanted to see if the implementation of the new rule would have any effect on the timeliness and process of the evaluation. So, using data provided from the New Mexico Behavioral Health, we gathered information on 1,528 competency evaluations. However, for individuals with multiple evaluations for the time period, we selected their first evaluation, which included 1,418 individuals from all districts within the state. We began finding key variations between key times in the competency proceedings, which include the time the evaluation is ordered to the date of evaluation, the date of evaluation to date of report date, and the report date to date of disposition case. First, we look at the median number of days between events by custody status and competency finding. We found the median number of days between order date to report date were very similar, regardless of custody status. However, time to disposition was significantly longer for defendants found competent. For those in custody and found competent, time to disposition was 105.5 days, compared to 45 for those found not competent. Those out of custody and found competent, time to disposition was 130 days, compared to 39 days for those found not competent. We broke it down further by judicial districts, for order date to report date, which varied across through all districts, with Bernalillo's Metro Court having the shortest median time of 28 days, while the 8th Judicial District had the longest of 81 days. When considering competency and custody status, we found for defendants in custody found competent, we had a low of 19 days for Metro Court and a high of 97 days for the 6th Judicial District. As for those found not competent and in custody, the low was 22 days and a high of 75 days. The low was for the 7th Judicial District and the high was for the 5th. As for defendants out of custody found competent, we had a low of 33.5 days for Metro and a high of 128 for the 8th. While those not found competent had a low of 31 days for Metro and a high of 93 days for the 13th. Overall, we found for most judicial districts, majority of defendants were found not competent. However, this is not the case for the 8th, 9th, 10th, and 12th Judicial District. We had a rule change that took effect February 1st of 2019. It was designed to create a more effective, timely way to identify if someone was competent to stand trial. we found that the rule change indicated the number of days from order date to report date decreased after the rule change. However, please take into consideration, we do not know how many outstanding evaluations were around, so we have to take that into consideration. Regardless of comparison, the 8th Judicial District had the longest time prior to the rule change of that 96.5 days. Post rule change, it decreased to 31 days, giving us a median of 81 days. Furthermore, we found that the percentage of individuals in custody and competency finding were not substantially different regardless of the rule change. As for overall competency findings, we found custody status and gender had no significant effect on competency finding. Additionally, the percent of those found not competent was higher than those found competent. Looking more in depth at competency and types of cases, we found defendants charged with misdemeanor cases were more likely to be found incompetent, with 63.9% of misdemeanor cases found incompetent compared to 57.4% of felony cases. As for race and competency, we found that both African Americans and Native Americans have significantly higher possibility of being found incompetent compared to other races. Regarding competency and age, those 25 to 34 had the highest request for competency, while defendants aged 35 to 44 had a slightly higher percentage to be found incompetent. As for prior assessments, we found that those 25 to 34 were statistically more likely to have a prior evaluation. Additionally, individuals that had previous forensic evaluations were more likely to be found incompetent. Even though competency evaluations is primarily concerned with those 3 key points from earlier, we're going to go into supplemental information on psychiatric diagnosis. Because there were over 400 conditions, we recoded and grouped them into the following: personality and mood disorders, anxiety disorders, psychotic disorders, and neurodisorders. We found that only 6% of individuals did not have a diagnosis, and the most common diagnosis was psychotic disorders, which include disorders on the schizophrenia spectrum and other psychotic disorders. Lastly, those with psychotic and neurodisorders were more likely to be found not competent. We finish up with our findings. We are going to go into our next portion, and I am honored to introduce our guest speaker today, Scott Patterson. Scott is the statewide behavioral health manager for the New Mexico Administrative Courts, is a licensed professional that has been working in New Mexico behavioral health field for over 20 years. His work focuses on modeling and supporting best practices for anyone involved in the criminal justice system, with a goal of improving outcomes by increasing trauma-informed and trauma-responsive engagements. Scott is currently working on multiple initiatives aimed at improving outcomes for justice-involved individuals, to include providing deeper understanding of the sequential intercept model framework, addressing gaps in treatment connections for individuals with competency-related issues, and providing behavioral health support for treatment court programs statewide. So welcome, Scott.
Thank you so much, Angelica, and thank you to everybody for joining us today, and thank you for the commission for the opportunity to talk to you all today. So to start, we're going to talk a little bit about behavioral health and hopefully highlight some of the programs that are happening in the state of New Mexico, and we'll also highlight some of the programs, like Angelica said earlier, that are happening across the country. And I want to start with a conversation about health in general and trauma, and then we'll move to the sequential intercept model, and then we'll talk a little about treatment court. And so, Angelica, if you could move to the next slide, please. And so, what is health? I think when we're working in the criminal justice system, that's a really important question to ask. And when we talk about health or we talk about behavioral health, we have to consider things kind of overall. And I'd like us to start with an operational definition, essentially. And there's a few definitions that we have when we think about health. Oxford English Dictionary says it's a state of being free from illness or injury. The definition that I prefer more is the World Health Organization, talking about a complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And also, according to Norman Sartorius, it's a state of balance and equilibrium that has an individual establishes within her or himself, and between her, himself, and his social and physical environment. The important thing too is when we're thinking about behavioral health in general, we have to think about health. And SAMHSA, starting in obviously for several years, but really started in 2014, made a concerted effort to look at trauma and look at the way trauma impacts individuals and the way that that impact of trauma actually plays into behavioral health issues. So when SAMHSA thinks about trauma and a trauma responsive approach to behavioral health, they talk about behavioral health being the promotion of mental health, resilience, and well-being. And it's really important to note that, in my opinion, the most important thing when we consider health is that it's more than just the absence of a disease or disorder. And next slide, please. So then when we're talking about trauma itself, we can look at the definition that SAMHSA gave us in 2014. It's a mouthful in my opinion, but according to SAMHSA and kind of accepted worldwide, individual trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. When we're working with individuals who are involved in the criminal justice system, sometimes this is a lot to digest. And so if I am talking about trauma with somebody who is in the criminal justice system or in the court system, I will frame it in a different way. I will say that trauma is really just something deeply distressing or disturbing that may have happened to somebody and then impacts the way that they go about their life. The reason why it's important for us to consider trauma and behavioral health when we're thinking about competency and behavioral health in general is that individuals will experience a traumatic experience or experience just a regular experience in a way depending on how they have been raised, what their environment looked like, if they had any epigenetic factors, so if they had generational trauma, anything that played into that. So when we're looking at the criminal justice system, often trauma itself will impact the way that somebody can actually process the information from the attorney, from the judge, from any individual. And so it's important, again, to think that similar or same events can be experienced and processed by individuals in different ways. And we're going to move to a discussion about the sequential intercept model. And if we can go to the next slide, please. So some of you have probably received emails or phone calls from me or from some people on the Z team, or you may have worked on one of the SIM mapping projects. So the sequential intercept model is truly a way to look at how we can leverage what exists in our communities, how we can identify the gaps that may exist, and how we can create interventions or ways for individuals to connect to meaningful engagement at multiple parts across the system. So if you notice, the sequential intercept model has intercept 0 through intercept 5. And initially it was a linear model developed by Policy Research Associates. It's currently in use across multiple systems as a framework for guiding engagement. And in New Mexico, we are asking people to look at it as a lens for interpreting or figuring out how do we engage with those individuals who may have competence issues, how do we engage with those individuals who may be high utilizers of the system, or how do we just support the community in general to make sure that people are able to engage in their life in a way that's meaningful to them and that keeps them out of the criminal justice system, if at all possible. And the next slide, please. So again, this system encourages community-based solutions. So it encourages systems to leverage existing and potential resources to develop responses for individuals that work in the community where they're happening. It requires cross-system collaboration. So it requires people to be invited to the table to have a discussion about what is going on, what are those gaps, what are those things that we're seeing with the individuals who keep on coming to the system, and how can we address those in a way that can reduce criminal justice system involvement for individuals with mental illness or substance abuse needs. Many of you may be familiar with the community mapping framework, so the sequential intercept model mapping framework, which is typically a 1 to 2 day workshop that brings community stakeholders across the board together to have a deep discussion about what is actually going on in the community and to talk about what are some of those resources or what are some of those interventions that may be beneficial. And we're going to go over what some of the best practices are across each one of the intercepts. And if we can move to the next slide, please. So in intercept 0, and this is pre-arrest. So this is for those individuals before they're in front of a judge, potentially when an officer has been called out to meet with them, or when there's just some concerning behavior, some concerning symptoms or lack of symptom management in the community. So Intercept Zero really looks at mobile crisis outreach teams and co-responders, emergency department diversion, and police-friendly crisis services. So what it's looking at in Intercept Zero, it's inviting communities to look at, can we have co-responders, or can we have alternate responders? Can we have, in some communities across the state, particularly Alamogordo, Albuquerque, we have teams where a licensed behavioral health clinician may respond to an individual in lieu of a police responding, or they may respond in tandem, they may respond together. When we look at the emergency department diversion, it's an opportunity for us to have embedded social services, embedded mobile services, peer support specialists available to engage with individuals in a way that's meaningful, or to have triage services. And when we look at police-friendly crisis services, what we're really talking about is some of the communities are standing up. I believe Las Cruces is working on this, as is Santa Fe. How do we have what nationwide is determined or typically called like a living room model or a drop-in center? If somebody is truly having a behavioral health emergency, can the community create a system where they can go to a crisis service for stabilization in lieu of going to jail, or in lieu of being arrested, or in lieu of going to the emergency room? What we know in rural New Mexico, often individuals are getting their behavioral health needs met through the emergency room, and that's really acute one-time care, so it's not necessarily appropriate for long-term stabilization. When we look at Intercept One, there are a few things that are considered best practices. So dispatcher training, specialized police responses, and high utilizer specific intervention and follow-up. And again, when we talk about high utilizers, I want you to consider those individuals that Angelica was talking about. I believe, I'm gonna misstate the statistic, but I believe she said 63% of the individuals are misdemeanors. And when we think about what judges and public defenders and defense attorneys are seeing across the state, often they'll see individuals who have competency-related needs. So their symptoms are not being managed in a way that helps them to move forward, continuously pick up misdemeanor charges, whether it's stealing, petty theft, or loitering, things like that. And so when we look at competency, if we can get interventions for individuals who are experiencing behavioral health emergencies or who are experiencing psychotic symptoms that are not well managed, if we can get them connected to services that are meaningful, we may reduce the need for competency evaluations. And so when we think about high utilizer, think of those individuals who really have unmanaged behavioral health needs, and how can we address those needs in our community with the resources we have, or how can we identify gaps to address those? When we talk about dispatcher training, we talk about having dispatch trained to cue in or clue in to those things that an individual is saying when they're calling to report. If somebody is having a behavioral health emergency, it is the outcomes are typically better if they send a CIT trained team. So if they send officers who are trained in how to respond to behavioral health crisis and de-escalation, the outcomes tend to be better. And that's where we get to the specialized police responses. So allowing police officers to do the job of policing and not expecting them to do the job of behavioral health. So allowing them to help somebody de-escalate. In a long sim, we're talking about de-escalation and connection to the services that are meaningful. And if we can move on to the next slide, please. So best practices along Intercept 2 and 3. Intercept 2 is mental health, screening for mental health and substance use disorders. This screening can happen at arrest. It can happen pre-court detention. It can happen in the jails. It's just a brief pre-screening. And often this can be successfully implemented with people who are not licensed behavioral health providers. So not licensed clinicians can do a brief screen to see if somebody does or would benefit from behavioral health services. Data matching initiatives between the jail and the community-based behavioral health providers. Bernalillo County has been working on this for about the last 2 to 3 years, looking at how do we share information in a way that's meaningful so that we're not re-asking the same question over and over again, and we can streamline services or streamline connection to appropriate services. Pretrial supervision and diversion services to reduce episodes of incarceration. So if we have an individual who has untreated behavioral health symptoms and we're able to connect them to services to get those symptoms treated in an appropriate way, the likelihood of engagement with the behavioral health system, with the criminal justice system, decreases significantly. At Intercept 3, we have treatment courts for high risk, high need individuals, jail-based programming and healthcare services. So in county jails and Department of Corrections across the state, we have clinicians embedded, and they are working to make sure that they're appropriately and in a trauma-informed and trauma-responsive manner addressing the behavioral health needs of individuals who have criminal justice system involvement. Also, collaboration with the Veterans Justice Outreach, the VJO specialists from the Veterans Health Administration. Many individuals who work in the criminal justice system are not aware that the VA system has individuals who are targeted and who are employed to help those individuals with behavioral health symptoms who are under the veterans system to connect if they're connected with the criminal justice system. A VJO can help somebody with accessing behavioral health care, medical care, housing, a whole bunch of things. And so at Intercept 3, we really look at how do we make those connections if somebody's already incarcerated, or if we can divert them from incarceration and put them in a treatment court program. And next slide, please. So when we look at the best practices on Intercept 4 and 5, Intercept 4 is transition planning the jail or reach-in providers. When we talk about reach-in providers, a lot of us are familiar with outreach. So we release somebody from jail, we release somebody from prison, and we give them a referral. When we talk about in-reach providers, we're talking about providers who actually go into the Department of Corrections or to county detention facilities and start that process of engagement. And what we know is that if somebody leaves with a warm handoff referral, or if they know who the persons they're going to be working with, it's much more likely that they'll be able to engage in treatment. Medication and prescription access upon release from jail or prison. If somebody is working to stabilize their behavioral health symptoms, it is highly important for them to be able to have access to medications if medications are working. When we release somebody with a 3-day supply, that's usually not significant, right? It's usually not important. And so, or important enough, I should say, to help them continue medication-assisted treatment or whatever type of medication they're receiving to stabilize behavioral health. So in Intercept 4, when we make sure that there's that clear connection from incarceration to release and afterwards, people have a higher likelihood of having successful outcomes. Warm handoffs from corrections to providers increases engagement in services. That's kind of one of those things that's maybe, hopefully not an aha moment, but it's not something that we have done consistently across the board. It's something that the Department of Corrections is working on, it's something that the court system is working on, and it's something that the executive branch partners are working on as well, making sure that we're able to connect people to services across the continuum, and that services don't fall off just because somebody is in jail or in prison or in a pretrial or a treatment court program. At Intercept 5, we really talk about best practices being specialized community supervision caseloads. So that means that those people who are doing the supervision of individuals in the community have specific training to help people mitigate the symptoms they're experiencing, and to connect with the cross-system collaboration partners that they need to connect with. Medication-assisted treatment for substance use disorders. And really, when we look at medication-assisted treatment, often in New Mexico, we'll think of that as only Suboxone or methadone. And there are many other ways for people to engage in medication-assisted treatment. And so it's important in Intercept 5 that people are engaged with providers who can provide MAT that's appropriate to whatever symptom they're trying to manage. And also access to recovery supports, benefits, housing, and competitive employment. So we know if somebody has criminal justice system involvement and has a history of trauma and is experiencing behavioral health symptoms, it might be more difficult for them to engage in housing services or case management services or employment services. So it's important for us to be able to make sure we connect them and continue to connect them. It's not just a one-time referral, it's a continuous engagement. And the next thing I want to talk about is our treatment courts. And treatment courts really occur at Intercept 3. And treatment courts themselves were developed in response to the overrepresentation of people with mental illness and substance abuse issues in the criminal justice system. Treatment courts seek to divert select individuals with mental illness or substance abuse needs into judicially supervised community-based treatment. Those who agree to the terms and conditions of community-based supervision have a team of court staff, social services, and mental health professionals that will work with them to help them develop plans that will help them along their process so that they can engage in not only treatment, but so they can engage in daily life in a way that is beneficial, growth focused, and important and meaningful to them. Approximately 54 treatment courts exist in New Mexico right now. And I say approximately 54 because some of you on this call may be involved in efforts to stand up more drug court programs or treatment court programs. And you'll hear in your community, you may hear drug court, you may hear DWI court, you may hear mental health court, you may hear treatment court. At an AOC level and really on a national level, we refer to these as treatment courts altogether. And so I believe by the end of 2021, we'll probably have about 58 active treatment courts throughout the state of New Mexico. We have treatment courts in all jurisdictions or all judicial districts except for one. So I want to say probably least populated judicial district has been thinking about the idea and thinking about having a drug court or treatment court, but they don't currently have one. And if we can move to the next slide, please. So I'm going to go really quickly over treatment court types. And there are other types that exist as well. These are the types that when we really look at from a National Association of Drug Court Professionals or Treatment Court Professionals, these are the types that we typically see, and these are the types that are present in New Mexico. Adult Drug Court is the one that most of you are probably familiar with. It's a treatment-based program for adults charged with certain felony crimes or facing criminal prosecution. A DWI Drug Court is a distinct post-conviction court program dedicated to assisting participants with substance misuse needs. Family Dependency Court is a juvenile or family court aimed at aiding parents in providing a safe, nurturing, and permanent home for children while simultaneously providing parents with support and services to become abstinent from drugs or alcohol. And so often when we look at family dependency courts, we're really dealing with generational trauma. We're dealing with what we talked about at the beginning. How do we assist the parents who may not know better right now? How do we teach them to do better so that we're not creating a future of individuals who will need criminal justice system involvement? We also have a juvenile drug court. And if you want to go over to the next slide, please. And I say next slide because I forgot to erase. Juvenile drug court is incredibly important to me, and so I listed it twice. So juvenile drug court is a treatment-based program for juveniles identified as having problems with alcohol and/or drugs. And so really, when we look at interventions, juvenile drug court is a great place to intervene for those individuals who are in the juvenile age range, the adolescence age range, before they graduate to the adult system. Mental health or treatment courts is a treatment program it's a treatment-based program similar to adult drug courts. It seeks to divert select defendants with mental illness into judicially supervised community-based treatment. And lastly, we have Veterans Treatment Court, which is a treatment-based program similar to adult drug court that seeks to divert select veteran defendants with mental illness or substance misuse issues into judicially supervised community-based treatment. And the important thing to note is that we have specific standards that were published by the Supreme Court, I believe earlier this year, maybe in February. We have a Department for Therapeutic Justice within AOC that provides supports to drug court, treatment court programs across the state. And we also work with our cross-system collaboration partners to make sure that individuals are connected with those services that they need throughout the treatment court process. And next slide, please. So lastly, I'm going to talk very briefly about two projects that are currently pilot projects in New Mexico. Both of these happen to be in Bernalillo County, and they are targeted at individuals with competency-related needs. So when we have the Second Judicial District Competency Pilot Project, there was a really significant backlog of competency cases. And we know from what Angelica said earlier, we had a rule change in February 2019, that moved the timeline up really significantly. So from the date of an order for competency, a forensic evaluator has approximately 30 days to evaluate the individual and produce a report to go back to the court so there can be a determination of competency versus incompetency. The competency pilot project in the Second Judicial District was created to reduce the backlog. So they successfully reduced the backlog, and they have a few goals. Some of their goals, I'll give you their top 3 goals as I understand them. 1 is to provide quality evaluations. And 2 is to be able to submit the reports within the 30-day timeline. And third is to reduce the number of hearings requiring evaluator testimony. So they're doing that in a few different ways. They are, instead of having private contractor practitioners do the evaluations, they have specific evaluators do the evaluations. They also are utilizing a postdoctor fellow. They'll utilize, I think, starting next year, more postdoctoral fellows and mid-level practitioners. So under the supervision of individuals who have been doing competency evaluations, forensic psychologists for several years, these evaluations are produced in a way that is more streamlined. I believe if you ask them, and I agree, tends to produce better reports that are a little bit easier to digest. And they also have a really nice cross-system education component. And so part of this project has allowed the team to attract individuals from all over the country who are looking for postdoctoral fellowships specific to competency evaluations within the criminal justice system. And they've also spent a lot of time providing training to the judiciary, to criminal justice system partners in the Second Judicial District on what exactly is a competency evaluation, what questions it can answer, how we should be asking questions, how we can interpret the information, and what information we shouldn't expect to see. The other pilot project that I want to just briefly talk about is the Metro Forensic Navigation Pilot Project. And this is about 6 weeks old, maybe 7 weeks old now. But what it really does is it talks about how do we look at those misdemeanants, those individuals who have multiple engagements with the system, those high utilizers, how do we move them from a place when they're not found competent into connection with services? And so they're doing that by collaborating amongst a lot of cross-system collaboration partners. So they're working with BHSD, with UNM, with community providers, and with the court to make sure that those high utilizers, those top 20 individuals, I believe they started with 5, who really come in front of the court often. How do we make sure that they are screened appropriately, assessed appropriately, and then connected to services that are meaningful and services that are going to allow them to engage in life in a way that's not going to result in more misdemeanor charges or into more engagement in the criminal justice system? Their goals are, they have a lot of goals, but I think one of the main goals is the reduction of system involvement through engagement to appropriate services. So instead of a judge seeing Scott 45 times this year, if the Forensic Navigation Pilot Project is working the way that they have set it up to work, they may see Scott once or twice this year. But Scott will be diverted to engagement with potentially AOT, with MAT, with a treatment court if that's appropriate, to community case management, to community health, behavioral health, really all of those system needs that can be met to help somebody manage their symptoms in a way that allows them to not come to the attention of the criminal justice system or not need criminal justice system involvement. And next slide, please. And I would be remiss if I didn't plug our Behavioral Health Summit. So the Summit on Improving the Court and Community Response to Those with Mental Illness in New Mexico is by invitation only. And so some of you have received invitations or emails from me. The good news is that most of you on this call are engaged with a CJCC or Criminal Justice Coordinating Council. And so if you don't happen to be on a county team, we have asked the judges who are in charge of the CJCCs or whoever's in charge of the CJCC to distribute the information afterwards. And so we also have had a series of webinars with local experts and national experts doing a deeper dive into SIM. We have a webinar on competency coming up in June. And so if you are not on a team, expect your CJCC to have a recording of that they can distribute to you to look at probably about 30 days afterwards. And that's going to have Dr. Deborah Pinels, who's a national expert, and it's also going to have the team behind the Second Judicial District Competency Pilot Project. And then we'll have a pre-summit webinar in September as well. And if you can go to the next slide, please. And this is the slide where you think it's all over and you're done and you're not. So I want to point out that this picture, of course, is from Las Vegas, New Mexico, which is where NMBHI, our New Mexico Behavioral Health Institute, the place where we typically send people for inpatient restoration. So this was not the community's response to competency. This was the community's response to some really significant things that had happened for juveniles and kind of transition age young adults. And so the community, this is downtown Las Vegas, kind of encompasses the attitude and the approach that we're hoping everybody in New Mexico will have. We truly rise by lifting others. So when we can look at those individuals who have continuous criminal justice system involvement, and when we can connect them to services that are meaningful and that will meet the needs of their life in a way that will allow them to engage, then we're lifting them up. And then we're also reducing the burden on the criminal justice system, and we're allowing people to engage in life in a meaningful way. If you have any questions at all in the future, you're welcome to reach out to me by cell phone, by email, anything behavioral health related in the court system, I'm happy to answer. And before we let you go for the day, I'm going to turn it back over to Angelica, and we're going to cover some of those national programs. So
thank you so much, Scott. That was awesome. So we're just going to go ahead and go over just some of the nationally rated mental health programs. I'm going to make this as brief as I can. So we're going to start off with the Mental Health Service Continuum Program. Targets inmates with mental health problems that are expected to be paroled within the next few months, as well as parolees who are being released from crisis and mental health facilities. The program operates by determining level of treatment needed upon release and provides services to enhance individual functioning, as well as increase assistance for reintegration into the community. The overall goal was to reduce recidivism in mentally ill parolees and improve public safety. And their study found that the parolees who had used the program had 7% less likely chance of returning to custody within 12 months of release. Additionally, those in the program who had one or more contacts in the community-based parolee outpatient clinic had a 52% chance of less likely to return to custody within 12 months of release. The Mentally Ill Offender Community Transition Program targets inmates with a mental illness that has previously influenced criminal activity. In the program, participants are provided with coordinated pre-release planning, intensive post-release case management services, structured programming, daily contact, home visits, close coordination to community treatment team, and co-occurring disorder treatment to focus on substance abuse. The overall goal was to reduce recidivism, and what they found was 39% of participants convicted a new offense compared to 31% of the unmatched comparison, or the matched comparison. As well as 23% of participants were convicted of a new felony compared to 42% of the matched comparison. The Modified Therapeutic Community for Offenders with Mental Illness and Chemical Abuse Disorders are focused on offenders with mental illnesses and chemical abuse disorders while in prison. With the adaptations of therapeutic community programs for co-occurring drug abuse problems and mental health disorders, they use a less intense approach of utilizing encouragement from peers and self-help, in addition to flexible personalized plans for treatment. With this live-in reentry, leave-out reentry program, upon release, participants can choose to continue to the program for up to 6 months. With the overall goal to reduce illegal drug use, they found 75% of participants had not used drugs compared to the group of 56%. The last of the offender reentry, the last one is the last of all the offender reentry community safety program. This used to be called the Dangerously Mentally Ill Offender Program, and it's focused on those who have been classified as dangerously mentally ill by the Department of Corrections. Once designated as dangerously mentally ill, they are referred to the mental health services in the prison. This re-entry planning and specialized service program focuses on what specific assistance individuals needs and can also provide specialized services for up to 5 years post-release. The goal is to ease the stress of the community reintegration and reduce post-release offending. They found participants were 42% less likely to commit any felony within 4 years of being released compared to the control group. And approximately 28% of those committed a new felony compared to 48% in the control group. Participants were only 36% less likely to commit a new felony, with 16% of participants convicted for a new felony compared to the 25% in comparison group. If you would like any more information, please check out the National Institute of Justice. And again, these are just 4 examples of many on the website. So if you go ahead and look at them, you can see more information to include their methods, more research that they have. But this concludes all we have for you for today. If you have any questions, make sure to use the Q&A area. And if you haven't, please register for our next webinar, June 23rd. And thank you for joining us today. We did have one question earlier for the assessment that we did in FY 2019. It was just the adult population. They had asked if we did juvenile, so I just wanted to let you guys know. But yeah, are there any more questions? I'll give everyone a few moments to type up any questions you may have.
Angelica, they can put the questions in the chat as well if they.
Yes. Oh, good.
And I want to encourage you, if you aren't aware of the treatment court programs in your community, become aware of them. If you're not aware of who's doing the competency work, same thing, become aware of that. When we look at the individuals in the criminal justice system, I can't give you a specific percentage for New Mexico. I think we'd have to reach out to DOC and BHSD for that. But I think anecdotally, when we look at individuals with criminal justice system involvement, nationwide, a high level of those individuals have a really significant trauma history and have a current mental health or behavioral health diagnosis or substance misuse diagnosis. And so when we look at reducing competency-related issues, or when we look at reducing criminal justice system involvement, it's important that we're engaging with the programs that are able to connect individuals with meaningful services. Treatment courts, community restoration, inpatient restoration, case management, anything in the community tends to work, if it's meaningful for the individual, it tends to work to move them in a direction that'll help them not engage or not need to be part of the criminal justice system.
For anyone that's having internet issues, everything to include full access to the presentation as well as the recorded video will be on our website in the next few days, most likely today. But if you do guys have any other questions, looks like so far we don't. But yeah, please don't hesitate to reach out to me or Scott. Other than that, thank you so much. And I'm going to finish today. Have a wonderful day and take care.
Thank you.